Welcome, everyone. Welcome to our webinar entitled Pharmacologic Obesity Management, organized by the Order of Pharmacists of Lebanon Scientific Committee. We are pleased to have you. We are pleased to be together and to listen to our speaker. So it's our pleasure to have with us Dr. Batoul Saad. She's a PharmD, BC-ADM. She is a board-certified clinical pharmacist and diabetes care specialist. She has an extensive experience in ambulatory care, medication therapy management, chronic disease management, telehealth-based clinical services. She currently serves as a clinical pharmacist and diabetes lead at Devoted Health, where she develops pharmacy protocol, supports interdisciplinary care teams, and optimizes treatment strategies for patients with complex chronic condition. Dr. Saad has also delivered numerous educational presentations for healthcare professionals on diabetes, cardiovascular risk reduction, geriatric care, medication safety, and evidence-based prescribing. So it's really a pleasure for us to have you. Dr. Saad, we are listening to you. The floor is yours. Please go ahead.
Hello, thank you so much. So honored to be here. I'm excited to talk about this. I know this is a very interesting topic that is very popular. So let's jump into this. You can see my screen okay? Perfect. Okay.
Yes, yes.
So today we're going to talk about pharmacological management of obesity, mainly focusing on the medications that are covered to help with obesity and weight loss, and discuss a little further about what you need to be doing and how to prescribe it and how to approach with patients on it. So we're going to talk mainly about why this happens, the hormones behind it, and then again, what to tell your patients, and some new medications that Lebanon hasn't seen yet, or they're on the market and slowly coming up, and you may get some questions on them as well. So sometimes we look at it and we say weight loss should be easy, or why do we always just gain weight so quickly after we lose it? And how do these medications make a difference rather than just dieting and exercising alone? So typically, you have a hormone in your body that tells your brain that I have enough energy stored in my fat cells. And so I'm okay, I don't need to eat. But when we're losing weight, that hormone is it's not working the same. And so our brain thinks we're starving and we need to eat more. And that's what happens when we're losing weight, is this hormone starts saying, hey, we're starving, we need to eat. And that's why it's not something that's short term, it's something that's long term. So the brain is telling the body that we need to increase our weight, we need to get back to the level that we're used to. And with that, then we find ourselves going back and forth. Our metabolism starts slowing down. The calories we burn starts being less. And that is the issue with the weight loss. So diet and exercise alone does cause about 5 to 7% of weight loss on average. And most of it does come back. And it's not just willpower. You don't tell someone that you just need to stop eating. It's not that easy. Our body is literally fighting against us. So that way we can keep eating. And that's why these medications help. So this is why the pharmacist matters here. This is why we are more accessible than a doctor. We're the first ones to hear about the issues. We're the ones that if they have any problems with the medications, they're the one that call us. If they need to help with it, they're the ones that come to us and say, can you help me with this? I don't know if I'm doing it right. I think something's wrong with it. And that's why as the pharmacists, we're the ones that are jumping in. We're so important, and hopefully we'll just keep making a difference. So there's a few types of medications for weight loss. The ones we're going to focus on are Semaglutide, which is the Ozempic, and it works pretty well. It's been around for a while. It does an average do about 15% of weight loss, and it's once a week shot. The other one that is available is Tirzepatide, which is the Mounjaro Zepbound. It has slightly better effects. It does do about 21%, and it's also once a week. There is a medication, I believe I got told it's not available in Lebanon yet, but inshallah, it will hopefully be there soon. It's called orforglipron. It's available in America. It just recently got FDA approved. And it's a pill that you take. It's a once a day pill that has very good weight loss effects, about 12%. So we'll discuss that a little bit. And then the medication that's currently being studied is retatrutide, which has amazing results. It does show about 25 to 30% weight loss, and it is a once a week shot as well, but it's a triple hormone versus the semaglutide is a one hormone, tirzepatide is a double hormone. So retatrutide is a triple hormone. So we'll go over all of these a little bit more in depth, and hopefully we'll be seeing how the results are working and what the differences are and which one would be best for which patient. With semaglutide, so this is the Ozempic, it copies a natural gut hormone, so the GLP-1, and it's built to last about 7 days in the body. So that's why it is once a week injection. It helps make your brain think that it's full. So what it does, it controls the hunger and it makes you feel more satisfied. So when you are eating the food, it makes you feel like you are satisfied and full faster. It also slows down the stomach emptying. But that's secondary to the hormones that are occurring that's causing these effects. And there are 3 brand names for semaglutide. So it's Wegovy, which is approved for weight, Ozempic for diabetes, and Rybelsus, which is the pill form that is available. And that is also, all 3 of them are semaglutide, working very similarly. Same active medication, different uses. So with the semaglutide, which is again the Ozempic and Wegovy, I do understand Wegovy is not available in Lebanon yet. So it's slightly, again, same medication as the Ozempic, but slightly higher dosages. So you start at the lowest dose, which is the 0.25 milligrams, and you do this for 4 weeks. The 0.25 milligrams is not meant to do much. It doesn't really help with weight loss. It's more so to help your body get used to the medication because you are placing a new foreign chemical into your body. And so at the 0.25, you do that for 4 weeks. During those 4 weeks, again, you don't really expect to have much of a weight loss effect from that medication. And typically, some patients may experience a little bit of side effects, but again, this is getting your body used to the higher dose. So after the 4 weeks, we can go ahead and increase it up to the 0.5 milligrams. And that dose that's when people start noticing that they are beginning to not have much of an appetite. They're eating less. They're starting to lose weight. And you do that one for about 4 weeks. Some people are very good at this dose for quite a bit of time. They can stay on that 0.5 milligrams for months and still continue to be losing weight. Other people may not really experience any much at all with the 0.5 milligrams. They still feel hungry. They're still eating as much as they're used to. So it just depends. Every person is different. And so we just do whatever is best for each of our patients. You do want them to be on it for the 4 weeks though, because they will not get any effects of it for the first dose or 2, as their body is still kind of building that hormone levels in the body. Some patients need to go up to that 1 milligrams. Again, we do that at the 8-week mark. So we won't go up to the 1 milligram before we get to the 8 weeks because we want to do 0.25 milligrams for the first 4 weeks, then 0.5 milligrams for the second 4 weeks. If patient is getting benefit from the 0.5 milligrams, we stay on that as long as they are continuing to get benefit. If they are not experiencing any benefit and need to bump up, we can go ahead and bump that up to that 1 milligram dose. And at that dose, that's when they should definitely start feeling the curbedness of the appetite, the satisfactory of once they eat, they get full faster, and the slowing down of their meals. They may also then experience a little bit more of side effects. If they do, again, you just have to caution them on making sure they're making healthy choices about their eating, and that with time, the side effects do get a little less. Side effects are usually kind of nausea or stomach upset. If they are experiencing those, we want to make sure we're not increasing the dose quite yet. We want to make sure their body is getting used to that dose before we want to bump it up a little bit more. And if they miss a dose, that's when you kind of jump in there. So a lot of patients, you typically want them to take it the same day every week. So if they take it every Monday, then the next Monday they take the next dose, the next following Monday they take the next dose. But we're human, we make mistakes, we do forget. So it's okay. It's very typical for someone to forget to take it. So if the next dose is more than 2 days away, go ahead and take that medication. So if between Monday and Friday, they forget to take it that Monday, and then they go up all the way until Friday, they can go ahead and take that medication. Once it hits Friday and they're like, oh, shoot, I forgot to take my medication on that Monday, go ahead. We want to skip that dose because we don't want to double dose because at that point, we still want to take it that following Monday. So at that point, so Monday, Tuesday, Wednesday, Thursday, it's still less than 2 days away from that next dose. So we can go ahead and inject that missed dose that happened on Monday and then go back to regular schedule that following Monday. If they do find themselves that they don't remember until it's Saturday, Friday late at night, Sunday morning, they're like, oh my goodness, I forgot to take my medication on Monday. That's okay. We just go ahead, we skip that dose, and now we just take it that back to regular schedule that Monday. We do not want to double dose because that doesn't show any efficacy. In fact, all it does is just shows that you get a higher risk of side effects. So someone who takes that dose super late and then tries to take another dose will most likely find themselves throwing up very, very quickly soon after, and it stays in your body. So you don't really make that go away any faster. You just have to deal with the consequences. So we do not recommend double dosing. If you miss it, go ahead and skip it. How we want to keep this pen stored. So typically we have this semaglutide pen. You want to put it in the refrigerator. As long as it's in the refrigerator and it's not used, you can use it, leave it in there until the expiration date that's written on the box. If you pull it out of the refrigerator, whether you use it or you don't use it, it's good for 28 days. So we don't want to typically pull it out until we are using it because we only have 28 days, which is exactly the 4 doses the pen is designed for. So once you pull it out and you use it, great. It's a 1 pen, 1 dose, you can throw it away. If you are traveling and you're going somewhere for 4 weeks, you have that 4 weeks you could take it and you do not need to put it in the refrigerator. You can keep it with you at room temperature, not a problem. It's still good for the 28 days. Don't ever put it in the freezer. If you find your pen ever does get frozen, it does mess with the chemicals and it's no longer working. And so we definitely keep it away from the freezer, keep it in the fridge as long as you can. If you take it out, don't take it out and put it back in. You just want it, once it's at room temperature, khalas, that's it. You just want to keep it at room temperature. Here's some studies that show the benefits of the semaglutide with the weight loss effect because the semaglutide is beneficial for diabetes and for weight loss. So study number 1 shows those that took it with no diabetes, and they experienced about a 15% average weight loss from their body weight, and versus placebo, which someone who's took this pen that had nothing in it and just was injecting it, they only lost about 2% of their body weight versus the semaglutide, they lost about 15% of their body weight. Compared to study 2, which showed the semaglutide that was being injected in those that have diabetes, they did experience a little bit less of weight loss, but that's because they are also experiencing the diabetes benefit of it. So there's still shows that the hormone is still working in their body. They're still experiencing weight loss. Again, compared to placebo, they experience about a 3% weight loss. So still works very well with those with diabetes or without diabetes. Now, if you jump to study 3 is taking the medication with the coaching. And so the coaching is letting them know how we're pairing the medicine with lifestyle, not just medicine. So you're eating healthier, you're going to the gym, and we saw this as such an amazing benefit. We saw people started losing more weight while they're watching what they eat, and they're going to the gym. Versus study 4. Study 4 is an interesting one because you hear a lot of people who are like, well, how long do I have to take this medication for? I reached my goal weight. I wanted to lose the 20 pounds. I lost this 20 pounds. Am I good to stop taking it? This shows that those that when they reach their goal weight and they stop taking the medication found themselves gaining the weight back within weeks. It's about 2/3 of it. You gain it all back towards the end. So it's similar to taking like a blood pressure medication. When you take your blood pressure medication and you get to your goal blood pressure, we don't want them to stop taking that blood pressure medication because the minute they stop, eventually their blood pressure is going to come back up. And this is exactly the same with the weight loss medication. We find them that when they stop taking their weight loss medication, when they hit their goal weight, they regain the weight, versus if they continue to take it, they will be able to maintain that weight loss, if not lose a little bit slightly more. However, again, if we maintain the dose that they're on, or we reduce it slightly, we're not going to want them to, and we don't want them to lose any more weight. That's what we would do. And in that case, that way they're not regaining all the weight. They're actually able to maintain it for a long period of time. So most common side effects of the semaglutide is the nausea and diarrhea. And vomiting. Those are the main ones that we typically see. There's some constipation in there and other stomach issues. And in these situations, again, it doesn't happen to everyone. It depends on the dose. The higher you increase the dose, the more likely you are experiencing these side effects. And at this situation, we want to make sure that we help them through these. So if someone comes to you and they say, I am feeling very nauseous, I'm throwing up after every time I eat, we give them the recommendation to eat smaller, more frequent meals. So the smaller the meal, the less likely you are to experience the side effects. And you want to make sure to tell them to stop eating at the first sign of fullness. So when they start feeling like they're getting full, go ahead and stop eating. We don't want you to keep eating. We don't want you to push anything among that. And then you want to go really easy on the fried and fatty food, especially the first few days after injecting. I've had so many patients where they tell me that they experience extreme nausea and vomiting right after they eat. And so I ask them a little bit more detail, what are you eating? And it's usually something like, I'm eating French fries. And when they're doing that, that's when they experience it. And then I had them go a week without having anything fried. So avoiding the French fries, chicken tenders, anything of that sort. And they said they felt great. They did not experience any side effects. So it really does matter what you're eating. And so that's why we say this isn't just a magic medication. It is kind of a tool to help you lose weight. Makes you make healthier choices. It's really important to stay hydrated, especially if you are experiencing diarrhea. The water helps you maintain this weight, it helps you be healthy, and it helps you not want to eat as much, cover those cravings when you're not feeling hungry, and really keep those electrolytes up. Typically, the stomach upset does go away in about 1 to 2 weeks after each dose. Again, most people experience the side effects very soon, right after. The first 1 or 2 days are the most likely to experience side effects, and after that, it will calm down. If you have someone who's experiencing ongoing severe belly pain, that can be related to the pancreas. So that is something that they would need to check out. And any gallbladder issues would include, may occur if you hear people be like, what's going on with my gallbladder? I heard someone had to remove their gallbladder. That's more correlated to the quickness of the weight loss rather than the medication itself. So that's not actually correlated to the medication. And then of course there's you have to be aware of the thyroid tumor risk that are in animal studies. So if anyone does have any thyroid tumors in their family history or themselves, we do not recommend this medication. So that's something to always ask for before initiating the medication. And now jumping into tirzepatide. So tirzepatide is the two hormones, the GLP-1 and the GIP. And these two work together to get the super effect of helping the weight loss. So separately, they don't work. They work okay. Putting them together, we found that they have a great synergic effect and they help with the major results. So what the likeliness behind that is because it may cause better insulin response, and it's helps affect on the fat tissues, reducing the fat, and easier to tolerate at higher doses when they're together, so less likeliness of side effects. And with this one, we found an average of about 21% weight loss versus the 15 with the semaglutide. And it comes in two brand names. So it is the Mounjaro for the diabetes or Zepbound for the weight. Again, they're the same medication, just different brand names. And the dosing is definitely a little different than semaglutide. There are more dosing options, but similar titration schedule. So again, we start at that 2.5 milligrams is the starting dose. And again, this one is just starting. It's not for maintenance. Someone should not be experiencing any benefits at that 2.5. If they are, it may more likely be a placebo effect than anything. So we do want them on that 2.5 milligrams for the first 4 weeks to get their body used to this medication, to start getting them less likely to experience any side effects. And then from there, we want to go ahead and increase it to that 5 milligrams after the 4 weeks. And that would be technically the first initial starting dose that you will see noticeable effects from. You do that one for 4 weeks as well. And then after that, you assess the patient. If they're still experiencing weight loss, you can keep them on that 5 milligrams. If they're not really experiencing any weight loss, no side effects, go ahead and bump them up to that 7.5 milligrams for another 4 weeks, and so on and so forth. You have the 7.5, the 10, the 12.5, and the 15 being the maximum dose. Again, we don't ever want to jump a dose. That doesn't really increase your risk of having severe side effects. And extreme weight loss. You will find someone who jumps the dose will find themselves be so nauseous and having extreme vomiting that they're not eating anything, and that causes then electrolyte imbalance. We've seen the nutritions go down. So we don't ever want to encourage that step. We want to really make sure we're going as low. The lowest, most effective dose is always the way to go. So if they're having a low dose and it's effective for them, keep them on that as long as possible until they're not really getting an effect. And that's when we consider bumping it up. The missed dose with this is slightly a little different. So if it's within 4 days of the missed dose, take it right away. If it's past the 4 days, skip it to the next dose. So you have a little bit of similar to the semaglutide, where you have like that Monday, Tuesday, Wednesday, Thursday. Once it gets to that end of day Thursday, you really do not want to go ahead and take it. You want to skip that next dose and wait for that following regular routine of that back to the Monday. This is because it just lasts a little longer in the body. So we definitely want to make sure we're not, again, doubling up on the missed dose and increasing the risk of the side effects. So very similar. Semaglutide has a little bit more leniency, so you could take it through Friday. The Zepbound could take it through Thursday. But I always tell my patients, just to make it easy, if the next dose is closer than the last dose, go ahead and skip it. So if you find yourself that in the middle of the week, oh my goodness, I forgot to take it, and my next dose is just a couple of days away, that means your last dose is just a little bit longer than that. Go ahead and skip it and just focus on your next dose. So that way we're not doubling on accident. Zepbound, again, there's the single dose pen, which is 1 pen injection. Again, you keep it in the refrigerator, and that's good for the expiration date that's written on the box. Once you pull it out of the refrigerator, it is only good for 21 days. And again, that's 21 days versus the 28 days with the semaglutide. At room temperature, it's okay for 21 days. It's 1 pen, 1 dose. And with that, then we go ahead and we use it, and then we throw it away. We want to keep it out of the fridge. You don't put it back in the fridge. You never want to put it in the freezer. You always want to make sure the liquid is nice and clear. So there's 2 pen choices for the Tirzepatide. There's the single dose, so it's 1 pen, 1 week, or there's the quick pen, which you can get 4 doses out of it. It's good for that 30 days. So that's also a difference between the single dose pen and the 30-day, that's quick pen. The single dose is only good for the 21 days, and you do have to throw it away after 21 days at room temperature. The quick pen, it's only good for, is good for 30 days, but you do have to, again, you have those 4 doses in there. So once you use those 4 doses, then you throw it away. If you find yourself that you have medication still in there after your 4 doses, you would still want to throw it away, because at that point in time, you cannot guarantee the efficacy of the medication. You cannot guarantee that there's enough preservatives in there. The manufacturer was not confident in this, and so they do not recommend this. So again, single dose, you inject it, and you throw it away. Quick pen, you have 4 doses in that. Each time though, the single dose pen does have a needle in there, so you do not have to do anything. You just take the cap off and inject it. The quick pen is something that you do have to put a needle in there every single time and take out the needle and throw it away every single time, along with priming it. You do have to prime the pen to make sure the needle is working properly. So all of that is built into the pen. And so that's why sometimes we have our patients say, well, there's still some medication in there. That's because there is a little extra medication for you to prime the pen to make sure that you are injecting the medication when you are injecting it. So that all depends on the patient. If some patient is comfortable with putting on needles and taking the same pen for multiple weeks, go ahead and give them that quick pen. If someone's is not really comfortable with different needles and looking at it and seeing all of these different ways to do it, we want to make sure just give them that single dose to make it a little easier on them. One is not better than the other. They are the exact same medication. This now comparing the different studies with the Tirzepatide and the weight loss, we find that Tirzepatide with patients that do not have diabetes that are just injecting the Tirzepatide do experience a 21% body weight loss compared to about 15% that was with the semaglutide. Again, placebo had a very low 3%, but it's still, and sometimes placebo does work. Sometimes people think they're injecting the medication and they're like, yeah, I'm eating a lot less. So that's the placebo effect of our body. Then study 2 shows those with diabetes that are taking tirzepatide and compared to placebo, and they did experience about an average of about 15% of body weight loss compared to placebo. And then we jump into study 3, which is lifestyle. It shows people that are pairing the medication with, again, exercise and diet, and finding that they on average lost about 27% of their body weight, which is incredible compared to, again, the placebo of it. And study 4 shows those that stop the medication when they reach their goal weight compared to where they are now, compared to if they continue to take the medication. So a lot of them did find themselves gaining the weight back versus if they continue to take it at what they were doing, they continue to be able to maintain the average body weight loss. And that's following about 72 weeks of trial. All right, and then the most common side effects for the tirzepatide are very similar to semaglutide. So again, mainly nausea, diarrhea, vomiting, with constipation and stomach issues. So very similar. We hold the dose to reduce the if someone is experiencing the side effects, you kind of hold the dose, make sure we're not increasing it. People are more likely to tolerate this medication. We find a lot of people usually stop at that 10 milligram mark. We don't really see the maximum dose on this medication because people are getting such amazing results from it early on. So it is definitely one that's favored between the two. I have seen with a lot of patients, if I give someone tirzepatide and they experience side effects, if I do switch them to semaglutide, they actually don't experience side effects, and vice versa. So I wouldn't say, so they are different in the body and every person is different. So if one doesn't work for one patient, it's okay to try another one and vice versa. All right, and then the best way to give the injection. So some people have never taken this before, and just kind of giving them the best places and best techniques to do it. There's 3 approved spots. You want to put it in the fat, not in the muscle. So the best spot to do it is the stomach area, about 2 inches away from the belly button. This is the place they will be getting the most absorption from. So it is the place I would always recommend. Some people struggle with that or don't really have much belly fat or struggle, just don't really have the concept of just, you have to squish a little bit of fat and inject it in there. If they're not able to do that, then we can go ahead and do it at the front of the thighs. Again, just put it in that fatty area or the back of the arms. The back of the arms is a little bit more difficult, but sometimes when someone's having someone do it for them, that would probably be the easiest way for them. Make sure to always inject in a different spot every time. I usually like to say go from the left to the right, to the up to the down, because if you are injecting in the same spot, you will find yourself experiencing more scarred tissues, and that will then reduce the absorption of it. And it gets kind of bumpy and hard. We want to avoid that at all costs. So definitely making sure to just do a different spot every time. And then the best way to inject, the best techniques is to check the pen. You want to make sure that it's clear liquid, it's not expired. We always want to check that expiration date. And then we want to use an alcohol swab to wipe the spot. You want to make sure to let it dry. Some patients will say that they are experiencing some tingling or some pain a little bit when they are injecting. Most of the time, it's because they did not let the alcohol dry, and so it stings them when they inject it. You want to hold the pen flat against the skin, about a right angle, and just press and hold until you hear all the clicks are done. Once you hear the final click, you want to wait about 6 seconds to make sure that you are completely gotten all the medication inside of you, and then pull it out and throw it away. Some people will end up finding themselves pushing, clicking, and then when they pull it right out and then they find a little extract of the medication coming out, that's because they didn't leave it in there long enough. So we just want to make sure to wait about that 5 to 10 seconds after you hear that final click to confirm that all the medication has been delivered. Some common problems, like I mentioned, some bruising or stinging. So making sure to rotate the spot and letting the alcohol dry fully. There's leaking. You want to hold the pen a little longer in place, so that way it's fully absorbing in. If you don't hear any clicks or the dose looks incomplete, go ahead and they should be coming to the pharmacist, because we don't want them. Sometimes I have the patient, they're like, I can't tell if I actually did inject it or if I didn't. And then I'd rather be safe than sorry. I'd rather not have a double dose. And then that point, then be like, well, we're going to presume that you did inject it, and then next week we can go ahead and just re-inject at the regular dose. Again, we don't want to double dose and experience any side effects. If a pen isn't working, if it got too hot, if it was in the freezer, if it was expired, we want to make sure we're getting rid of those pens. And then when it comes to traveling, and again, we have that 21 days for the semaglutide, we have the 21 days for the tirzepatide, 28 days for the semaglutide. However, again, if they stay refrigerated, then they're good to go. Most planes will let you store it in the fridge with them. If you just let them know, hey, I have this medication that needs to be refrigerated, they will put it in the fridge for you. If you're just traveling, then you get a little lunchbox cooler, put some ice in there just so it stays cold. Again, we don't want it to freeze, we just want it to stay cold. And then that will just keep it at that refrigerated temperature. Some upcoming medications that are coming up other than the tirzepatide and semaglutide, so for more weight loss medications, we have the retatrutide. So that one's just around the corner. It's not currently FDA approved, so we are not currently prescribing it, but it has some amazing test results coming out from all the test studies that are showing. It is 3 hormones. So instead of just the GLP-1 and the GIP, we're adding a third hormone in there. And with all 3 of them working together, it helps you burn more fat and then raise calorie burning. And so that way you're losing weight a lot faster. It is still the same format of just the 1 shot once a week. So that isn't quite being taken away for those that are nervous about injections. But you are experiencing more weight loss effect, which is at a faster rate. So I think that is usually the goal here as well, especially for those that have a larger weight loss goal. So with retatrutide, there was actually this interesting study about it, is that not only did it focus on obesity, it did focus on knee pain as well. So it kind of focused on those patients who have obesity and have knee pain. And within that, it showed the first major report showed the highest tested dose, showed that it experienced a 28.7% reduction in their weight loss. And then not only did they experience that, they did experience their knee pain improving quite a bit, which is a major positive. We know a lot of people, especially that have knee pain and they're overweight, their knees can't handle the weight. We're seeing the benefit of the knee pain reduction and the weight loss. And then it did include type 2 diabetes as well in there, which showed their A1C reduction. So all 3, experienced the weight loss, the type 2 diabetes, and the knee pain, just had amazing benefits. A side study that had been occurring as well is that with sleep apnea, so those that are sleeping and just finding themselves like having to wake up in the middle of the night with breathing interruptions, there was the study is being done on that as well, and it showed benefits for those with sleep apnea, which I believe tirzepatide is approved for that as well. So it kind of has all these different benefits from all these different medications all in one injection. So it'll be really exciting to have this approved soon. Again, this is a large study. It's going over 10,000 people that are being studied in it. We do expect it to be FDA approved in the next few months. So just waiting patiently until we can actually prescribe this medication. The retatrutide starting dose is about 2 milligrams per week, and then the higher doses go up to 4, 9, and 12. Again, it would be similar titration. They're expected to be about every 4 weeks, and again, monitoring for the side effects. And hopefully it will be approved again soon. So I would keep an eye out. I would probably see it on the market hopefully before the end of this year. The main common side effects of it are the stomach. So again, just the nausea, vomiting, diarrhea. And some people actually experience some skin tingling and numbness. Not very common, but it was something a little different than the other ones. And it showed good effect on the cholesterol and the blood pressure. So again, we're just seeing all these benefits from this medication. So it's been helping with the fatty liver findings as well. So it would be a great addition to add on. It might be even the number 1 as we continue to study it. And this is kind of a little bit of comparison of the average percent body weight between all of these different medications. So we saw the semaglutide has about 15% reduction versus the tirzepatide is about 21. Retatrutide showing about 28%. And then there is that one pill that I mentioned at the very beginning, which is the oral tablet that you can take. And it is once a day tablet. It helps with weight loss. It is slightly less than the others, but again, for someone who is scared of injections or not comfortable with needles, this would be a great alternative. Again, this is called orforglipron. It was approved earlier this year. It doesn't need to be refrigerated. It's a pill. It's once a day. You don't need to take it in the morning. You don't need to take it with a specific amount of water. It's just something that you take, and it helps you have good reduction in your weight loss. There had been some talks about glutide, and it's not a medication. Honestly, I wasn't very familiar with it. It's not anywhere discussed in the States. And it's actually made by a South Korean company, and they are more doing this as a supplement rather than a medication. So it's not something that is very well studied. And all the studies have been by this company in very small trials. So I would not recommend it over the other medications, but it is something that is being discussed and has been brought up. So it's more of a protein, and it's within a small company. So I wouldn't rely too much on it. And this is if your patients do come and ask you about it. And then these are some things you could say. You say the evidence is weak. Most claims and research is from the company, so it's not an independent study. There's no outside check on the quality or the purity, so you don't really know what you're injecting. There's no long-term safety records. And it usually breaks down in the body because it is a protein. It breaks down in the body before they can actually work. So I would tell the patients to really focus more on the prescription medications that do have the FDA approval, that we do know the test results, and we can actually answer the questions about them. So over time, we want a healthy pace for weight loss. I know there's so many people, we have just so much we want to lose, and we're really trying to lose as much as possible, but we want to maintain a healthy weight loss because losing weight too quickly can cause more harm than good. So the average we want to lose is about 0.5 to 1% of the average weight loss, because that way we're still keeping the muscles there. We don't want to lose that. And that shows about the 84%. And that was something that comes straight from the manufacturer with the semaglutide. And they said about 84% of weight loss with fat mass still preserves the muscle. So as long as we're having a good, healthy weight loss, 84% of those that lost the weight were still able to preserve their muscle mass. So it's really just, that's what's we hear about a lot, is when you're taking like the semaglutide, people are losing their muscle mass, and that's because they're not doing it a healthy way. So we want to make sure we're still getting our nutrition, we're still having our hydration, and we're still finding that weight loss while we're also not affecting ourselves. Okay. And then what do we do when someone says they're plateauing on they're losing too fast? So we kind of have to have a solution. If someone says, I've been taking this dose and I'm not getting anything out of it, that's when you start looking into it. You start saying, hey, are you injecting the right dose? Are you injecting it correctly? Is something wrong with the pen? And then we kind of, again, check that for the 4 weeks. If everything is being done correctly, we can go ahead and then consider raising the dose. We also want to make sure we're talking about protein goals. We want to make sure that they are exercising and eating healthy. So again, we don't just want to switch the medication. We don't want to just increase the dose right away. We want to investigate a little bit. If they're losing too fast, that's when we want to make sure that they are eating well. We really want to focus on the eating portion of it. So some people purposefully starve themselves when they're on this medication. So we want to partner with a dietitian. We want to assess that. We also want to make sure that the dose isn't too high. We can always reduce the dose. Reducing the dose is not an issue here as long as it's being effective. And then again, keeping the muscle while losing the fat. We want to eat more protein. Protein and exercise is the perfect balance to keeping the muscle and helping lose weight. So just want to make sure we discuss that with the patient every time we see them. So once again, I discussed about what happens when you stop the treatment. Most people gain about 2/3 of the weight they lost. And it starts happening pretty quickly. So after they stop it, they find themselves maybe in the first like 2-3 weeks, they're still doing okay. After that, they find themselves gaining 1 or 2 pounds at a time. And eventually over the year, they'll find themselves gaining most of the weight back. And so it is something to discuss with the patient that you are starting this and you want long-term effects. You will be taking this medication for a long period of time. Things to look out for is who's the best candidate for it, and that would be with their BMI. We typically recommend it if their BMI is above 30 or if it's BMI of 27 with any health problems, such as high cholesterol, high blood pressure, diabetes, anything of that sort. And of course, making sure we're doing good diet and exercise along with that. We want a good, healthy lifestyle. We want to use caution with anyone that has any issues with their stomach or their pancreas, or an eating disorder, because again, we find a lot of patients do tend to starve themselves, and we do not want to encourage that. We want to have a healthy weight loss. We do not want to give this to anyone who with a thyroid cancer history with them or their family, or if they're pregnant or trying to conceive, or if they're allergic to the medication. And then again, these are someone's having their knee pain or fatty liver. Retatrutide might be the best option for them. If they don't want needles, again, there's the pill option. If they're not seeing good results, Tirzepatide tends to have better results. Things to check on the way is their weight, any side effects, how their blood sugars are doing, their kidney function, cholesterol levels, gallbladder, and injection techniques. So these are all things we just want to assess anytime they have questions on them, or if they're feeling like they're not having good results. We should always be assessing these. And between insulin and blood sugars. So typically, again, this medication is mainly used for people with diabetes, so it does reduce the insulin, does reduce their blood sugars. So if someone is on insulin, we want to make sure they're monitoring their blood sugars, make sure that it's not getting too low, maybe reducing their insulin dose if they are on insulin. Birth control has been a controversial topic with this, because if someone is taking a pill, again, these medications do slow down the gastric emptying. So medications are not being absorbed as quickly as they typically are. So again, same thing with blood thinners or any slow stomach medicines or anything of that sort. We are not getting the full effect of the medication as quickly as we would have when we're not on these medications. So people should be kind of watching these, getting them monitored, and being more careful and aware of it. Semaglutide and Tirzepatide are not interchangeable. You can't say, well, I'm taking Semaglutide 1 milligram, put me on the Tirzepatide 1 milligram. It doesn't work like that. You have to, each medication is different. You kind of assess it. You can reduce down. You can definitely switch the doses. Most people do recommend to switch back to the very beginning. But for me, with my patient history, if I've had someone who is on that Semaglutide and then they're on that 1 milligram, I would not go ahead and put them on that Tirzepatide low dose. I would go ahead and maybe bump it up a little bit. They maybe put them on that 5 milligrams instead of that 2.5 milligrams. But again, every patient is different. You just have to see which patient, how the patient is reacting, their side effects, and assess all of that. And again, special situations. So if someone has kidney issues, they're low creatinine clearance, there's no special dosing for it. We just want to make sure they are staying hydrated. Same with liver, no issues there. Pregnancy, again, not typically studied, so it's not recommended. And with children, semaglutide has been approved for the age of 12 and older. All the other medications are for 18 and older. Again, higher risk of muscle loss with especially the older adults, just because that's how we naturally are. So just making sure that we're not losing weight too quickly, and making sure we're having our protein and exercising. And after weight loss surgery, this can help with those that have had weight loss surgery and are starting to gain weight again. So it's not contraindicated in that situation. Some questions that may come up: how much weight will I actually lose? Typically, you want to give them a little bit of a range, about 15 to 20%. But everyone's different. Just depends on your lifestyle. We want to make sure we're including lifestyle, as we saw from the different studies. Why hasn't it kicked in yet? First dose, again, doesn't do much in there. So we just want to make sure first dose, we are just monitoring it. It's just helping your body get used to it. As we increase the dose, you'll start seeing it. Again, it's not the first dose. You'll see after a couple, 2-3 doses on the upper dose as well. Can I stop once I reach my weight goal? If you can definitely stop it. But once you stop it, you will definitely be gaining some weight back. So just being aware of that, and recommending that instead we are maybe maintaining a good healthy dose for you, where you're not gaining weight and you're not losing weight. We're just finding a good healthy dose for you. The nausea is bad. Should I just stop taking it? I wouldn't stop taking it. This is where we assess their diet. Are you eating a lot of fatty food? Did you just increase the dose? Did you just inject it yesterday? So it's a little bit more hard on your system. We let them know the longer they take it, the less those side effects will occur. If they are really struggling with those side effects, we can then reduce the dose a little bit. Again, I heard these medicines cause muscle loss. Any weight loss can cause muscle loss, but if you're eating enough protein and exercising, that should not be the issue. Is it safe to drink alcohol, get pregnant, or have surgery? Alcohol usually does make the stomach upset worse. And then again, planned pregnancy is not something that's been studied with it. And as a surgery, talk with your surgeon. They'll be the ones to tell you. And then as of this, again, if you're losing too much weight, we want to reduce the dose. If you're losing a good amount of weight, we continue with the dose. If you're not losing weight, we want to increase the dose. So it's definitely just to assess it about every 4 weeks and determine from that. So just the key takeaways, this is a long-term condition. It's not something that they'll just be on for a short period of time. Erasing doses does increase your risk of side effects. We're shooting about for a 0.5 to 1% weight loss a week. Retatrutide is looking promising, and the supplements are not the way to go. So this all came from the manufacturer websites. It all came from studies. It's all real facts. And hopefully when you approach your patients about this, you can let them know the same thing and say it with confidence. And that is it for me. Thank you.
Thank you. Thank you, Dr. Saad. It was really a very enlightening presentation. We really liked it. And the proof is that we have lots of questions. So let me start first by someone who asked about whether the webinar is supported by the manufacturer. So just I would like to disclose that this webinar was not sponsored by any manufacturer, any pharma company, any sponsor. So it's just an OPL webinar, and we were helped, thankfully, by the Science Pro. So this is just for your information. So I'll start by the first question. Can the semaglutide be given to patients with cirrhosis?
Sorry, I got jumped into a call meeting. Semaglutide can be generally given to those with patients with cirrhosis, correct? Yes. You have to look at their level of cirrhosis. So if it's very active, that's something you should be talking with a specialist about, but it's not contraindicated in those that do have cirrhosis.
Okay. Why some patients are directly started on Mounjaro 7.5 milligrams?
That is typically, again, not the way it should be done. It should be started at that lower dose. That's the proper way of prescribing it. So if anything done differently, that is something the prescriber is doing on their own. That is not what the manufacturer is recommending.
Okay. All right. Um, Now, many patients buy the highest dose and then they start injecting lower doses by counting the clicks. Do you think this is an accurate way of doing it?
It is not. And I've had this happen with patients as well because it is a cost. It's something that will save them on some money and make the pen last longer. And I understand why they want to do this. But again, this is not something that was studied by the manufacturer. And it gets once after that, specifically with the Tirzepatide, after that 28 days for the quick pen or the semaglutide with the 28 days, you don't know the efficacy of the medication. You don't typically know what you're injecting. So at that point in time, we're not really sure what is going on, what you're putting in your body, and how well it is. And so at that point in time, once you are having to increase the dose, you may experience some side effects because what you thought you were injecting is not what you were actually injecting. So it's not something we recommend. I know is definitely tempting with the price with the price of things, but you're injecting this inside your body, and so we want to take care of our body, and that's why we just don't really want to experiment with that if it's not been tested.
Okay, so it is a risky process, yeah. Okay. Why do blood thinners delay the absorption of some of these products?
It's the opposite. So the
Uh,
medication will delay the absorption of the blood thinner, and that's because again, we're delaying uh, the absorption of it. So someone who's taking their warfarin every day, but they're taking their semaglutide, the first few days of that semaglutide, the absorption of it will be a lot less, and so because it's going a lot slower into the body. And so at
okay,
that point in time, we just want to just have a little bit closer monitoring until they can get the perfect dose for you.
okay, thank you. What about some blindness cases that were related to some of these medications?
I did hear about that. I think with a lot of medications, there's some very, very rare side effects that occur. So it could be just a gene within those specific patients. It's not something that's very common. It's not something that you hear about very often. And again, it's a small percentage that's in the light right now. But there's nothing correlated specifically to the medication says this medication is causing this. So it's not, I wouldn't be too concerned about it. Again, every person is different. Anything you put in your body, you're putting yourself at a risk for it. It is something foreign you're putting in there, so you can't guarantee anything. But again, it's such a small percentage. It's not something that's a common cause for this medication.
Okay. All right. Thank you. Now, what about the use of these medication in managing obesity in young female with PMOS, the insulin resistance issue? And do you think that this medication would replace or would avoid switching to diabetes medication for these patients, such as metformin or others? So in PMOS.
These medications are definitely effective in managing obesity in the young females that have PMOS. It is a unique one. It's very common. I know a lot of them tend to take metformin. That's usually the medication that helps with this chronic medication. I don't believe it's an alternative to give instead of metformin. However, it is something that could be an add-on. It's not causing any additional risk. In fact, I do think it helps these women with them being able to get their weight under control to be able to help with all the symptoms they experience with PMOS. But it's definitely not a recommended alternative. You can do an add-on.
Okay, thank you. Um, what could we recommend as pharmacists for patients who stopped using the GLP medications for more than 4 months and still they do not have a regular digestion?
As a pharmacist and who has, that's very seldom. I've only had it a couple of times, and at that point in time, I do refer them over to a GI specialist because at that point, it's out of our hands. There isn't really a medication where we say, "All right, let's speed this up. Let's get your digestion to be working well." If it really is that big of an issue and has been occurring for that long of a period of time, they should be seeing a specialist and having more internal imaging and things looked into at that point. Again, that's a small percentage. It doesn't happen too frequently, but it's out of the pharmacist's hands at that point.
Okay. Now, suppose that a patient has reached his target weight. You said that it should be a long-term treatment. You mean that this is a medication that should not be stopped? We just find a dosage that keeps him at a certain level of weight and that's it? And for how many years do you think we have enough experience to know how safe it is on the long term?
Yeah, definitely. Exactly. So essentially it is a medication that you are taking long term. It's not something that you take and then once you hit your goal weight, you just stop it. It's something that you do have to maintain. You do start on that lower dose. You can go to a lower dose. You can titrate your way down as well. So you can find yourself if you're on that 1 milligram of the semaglutide and you reach your goal weight and you don't need to lose any more weight, go ahead and reduce down to that 0.5 for a little bit and make sure see if you're still able to maintain that weight loss and you're still um, doing well on it. And then for that period of time, if you're still able to maintain it, you're doing well, go ahead and reduce down to that 0.25. You can slowly taper yourself off of it. Again, studies do show that you will gain some weight back. So keeping that in mind, if you want to lose that 20 pounds, go ahead and lose that 23 pounds because you know you're for sure going to gain back that 3 pounds anyway from stopping this medication. So just something to be aware of, or again, just playing with that titration. You stop it for a period of time, you end up finding yourself gaining that weight, go ahead and restart on that low dose and work your way up. So it's something you don't just want to put on and off. You just realize that it's
Kind
something
of maintenance dose,
you
you
will be
mean?
taking for a while.
Yeah, yeah. And what about if you have a patient who's allergic, who has some allergies, every time they inject the medication, they show some allergic reactions. Is it common?
It's not common. And again, we don't want to give it to anyone who is allergic to the medication. So if you find themselves being allergic to the semaglutide, go ahead and give that tirzepatide a chance. So they're not actually allergic to the whole drug class. They are allergic to that medication. So it's okay to alternate between the two. However, if it's an allergic reaction, like it's a injection site reaction, like they're finding themselves experiencing a rash every time they inject, That isn't too severe. I wouldn't be too concerned about it. I put maybe some hydrocortisone steroid cream on it whenever they inject in that same spot to help reduce the risk of that rash existing. Um, but I would not call that such a severe allergy that they can't take the medication.
Okay. Okay, thank you. Now, with the increase in number of these types of medications, how can we finally decide which medication to which patient? Are there any clear guidelines or decision trees that would tell you, well, for this patient you give X medication, for this other patient you give another one? Uh, the presence of diabetes, the presence of maybe liver problems. What factors would guide the physician when prescribing these medication?
Yeah, something I usually, this is where you have to put your clinical judgment in and you have to think about the patient and what's best for them. So at that point, you look at what if they have diabetes and their A1C is very high. We do see that tirzepatide does have a much larger reduction in the A1C numbers and weight loss. But if you look at your patient and you're like, okay, they have diabetes, but they don't really need to lose that much weight, semaglutide might be the better option for them because we don't want them to have such severe weight loss versus someone who right now tirzepatide is again for sleep apnea. So we recommend if they have sleep apnea, semaglutide isn't really going to help with that. Tirzepatide will. So it's just kind of knowing there's a little bit of different factors that you have to incorporate for every patient and see what one would be best for them. And that's again clinical judgment. There isn't like a yes or no. Every patient is different.
Okay. All right. Some more questions are coming. How much do these drugs affect the pancreas of a patient who doesn't suffer from diabetes? Um, could it cause pancreatitis in a patient who's quote unquote healthy otherwise, other than
Yeah,
this?
it can, absolutely, because I mean, at the end, our pancreas is the one that is the organ that's supplying the insulin, and so we are playing with the pancreas a little bit. The pancreatitis is not, again, it's not the very common, but it is something we do want to have the monitor for. Like if you have any abdominal pain, if it's severe, if it's lasting a long period of time, that was something I mentioned where it's like that's when you want to refer them to that specialist, tell them to stop taking the medication and go see a doctor for that. But does it happen very often? I can tell you in my 10 years of practice and prescribing thousands of these, I have not had it happen one time. So alhamdulillah, like thankfully that didn't happen, but it's definitely it has been shown in the studies and something to look out for, and that's something you have to assess with every time they come to get the fill of the medication.
Okay. You talked about prescribing. Actually, are these medication dispensed by pharmacists with prescription, without prescription, or it depends on the country? Now in Lebanon, we know that things are not that clear cut. But let's say in the States or in Europe or in Canada, how is it going?
Yeah, definitely. I can speak for the states. We definitely need a prescription to prescribe it. I am able to, with my certifications, be able to prescribe it myself. So I am able to prescribe it as the pharmacist, but typically not every pharmacist can do that. So
Candida. Okay.
but you do need a prescription.
All right. Okay. And a question, some pharmacokinetic question. Is there a washout period that you should respect if you want to switch between, for example, Ozempic and Monjaro or not?
Yeah, not typically a wash period. You would just do it on the same day of injection. So if on Monday you injected that Ozempic and the patient, you decided you want to switch the patient over to the Tirzepatide, you just have them then switch over that following Monday to that Tirzepatide. Again, we do want that dosing to be equivalent, but no wash period.
Okay. Someone is saying that in Canada, it needs a prescription, but the pharmacist can adjust the dose according to efficacy and tolerance.
Interesting. Yeah. And again, the in America, the pharmacists cannot do that. They can only prescribe what the prescription is. We can make recommendations, but the final call is based off of what the prescriber is the one that recommends it, not the pharmacist.
Hmm. Hmm. If people who have a normal body mass index take it, do you Do you find any indication, and do you think it's safe?
It's not. That's something we struggle with. There's actually like a few patients where I'm like, well, I'm getting married soon and I want to lose 5 more pounds. And it's like, well, I understand that, but this medication, I cannot give it to you with my clinical judgment because again, you can't really control that you're only going to lose that 5 pounds. It's something that you may lose a little bit more. It can have those side effects that you can experience those severe side effects that we can't control. So we typically deny them. We push them towards a dietitian and exercise but yeah, normal BMI. But again, if someone's already been on this medication and they reach their normal BMI, we can maintain them on it. It's okay to maintain them on it, but
Okay.
not start them on it.
Okay. And if someone is taking one of these medication and he wants to switch to another one, should he switch to the same dose or he can go to a higher dose if he's not getting the benefit, for example, from the first one?
So again, this is something where manufacturally it says that no, you do have to start at the lowest dose. However, you can put your clinical judgment in there. So if this patient is on that Ozempic 1 milligram, which is the higher dose, and you want to switch them to that Monjaro, you don't. I personally do not switch them over to that 2.5 because again, that starting dose is just to get their body used to it. I also then wouldn't switch them over to a 7.5 or a 10. So I would switch them to a more lower dose, but still not the lowest dose. So I would go from like a 1 milligram Ozempic to possibly a 5 milligram Mounjaro and see how the patient is tolerating it and assess after 4 weeks to see if they need to get anything adjusted from there.
Okay. Thanks a lot. Really, I think that we have no more questions. We would like to really thank you for all your insightful recommendations, guidance, and all the information you gave us. Really, thank you. I would also like to thank people from Science Pro, Dr. Carla Abu Salwan and Jad, thank you. You are really very helpful for us. And I hope that the pharmacists from the OPL enjoyed this webinar. And Dr. Saad, we hope to see you soon, either in another webinar or in person if you happen to be here. In 24 and 25 October, we have the yearly Congress of the OPL. So this will be a big event. So I'm telling also all the pharmacists who are attending now, we are waiting for you, and we hope to see you soon. Okay, thank you, everyone. And hopefully, our next webinar will be in September, before the Congress, actually. Hope so. Okay, thank you. Have a nice evening and goodbye. Bye.